Welcome to the Dr. Bergson's Best Health Radio Show, and we have on the show one of my very favorite gynecologists. He is a thinker, and he's going to help you today think about everything hormonal, perimenopausal, postmenopausal. We're going to ask him a lot of questions. In fact, we're naming the show Menopause, Hormones, Fact and Fiction with an Integrative Gynecologist. Welcome to the show, Dr. Jack.
Thank you. How are you, Lindsay?
I am doing great, and I want to tell people a little bit about why you're here.
Okay.
So you and I started lecturing together for higher board certifications when medical docs are a little bit exasperated with being regular medical docs. They can take 2 or 3 certification programs around the country that are anywhere from 2 to 4 years to become certified in what's called functional medicine, where you think outside the box. Functionally, not just an algorithm of meds in the way regular docs are trained. So you and I ended up lecturing together.
That's right.
And I just thought you were amazing.
Well, it was a mutual love, and we became very, very good friends very quickly, and it was just a great experience.
It really was, because I love to meet somebody who's smart plus heart and really thinks you really care about your patients. So now we've shared a number of patients together, and I hear so many great things about how you interact with people and how much they know you help them.
Thank you.
Thank
you. You know, it was funny when you mentioned integrative gynecologist. When I was doing my fellowship, and one of my teachers, Ron Rothenberg from San Diego, was talking, and I interacted with him a little bit. And he looked at me and he said, "What kind of a doctor are you?" I said, "I'm a gynecologist." He said, "Oh, a recovering gynecologist." So I became known as a recovering gynecologist because I switched from gynecology to functional medicine. So it was like I saw the light and changed. But
I love that. Well, I just want to give a really small snippet. I want to Vulcan mind meld a small snippet of who you are, and then get into some really dynamic questions that people, especially women that are sitting out there, maybe they're strolling by a lake, maybe they're getting dinner ready for their family, but these are questions that are laying heavy on their heart. So you're a medical director of Nashville Hormones, and I'm going to be lecturing in Nashville in September and hanging out with you and your lovely wife soon. You're board certified OBGYN and in anti-aging medicine. So you went through those functional medicine higher board certifications. And I remember you studying for months for those. It's a big deal to get that higher board certification.
Yes, it is.
So it's called a fellowship in anti-aging, functional, and rejuvenative medicine. And you've earned that on top of being a board certified gynecologist and medical doc. And you also have added nutrition to the club. So you got from the University of Southern Florida School of Medicine, you have a master's in nutrition, and you lecture nationally and internationally, which is where we met. And when you teach, you really, really learn things because you have to know things to share them.
Well, I love teaching, and it's just a passion. I mean, I do a lot of teaching in the office with my patients, and I just got back from a weekend conference here in Nashville where I lectured on functional thinking. So it's thinking differently. It's thinking functionally. Like that's what we're going to talk about.
What is functional thinking?
Well, functional thinking is thinking outside the box. In other words, we don't just take the symptoms, come up with a diagnosis, and give a drug. We think about how to fix the problem that's causing the symptom. The example that I use is you're driving down the highway in your car and your oil light comes on. So the functional treatment would to bring it to the garage and have the mechanic check things out. And if you need oil, he puts more oil in your oil pan, or if you have a problem, he fixes it and the light goes out. The conventional treatment is to lift the hood and cut the wire to the light, and the light will still go out. So either way, that light's going to go out. It's the approach that you take. So in functional medicine, the symptoms tell us where the problem is, and they direct us to how to fix that problem. And then once you fix that problem, the symptoms should go away. If it doesn't go away, then there's something else going on, or you haven't addressed the problem correctly.
So why is that not taught today in med school? What's going on?
Because we don't need the drug companies to do that.
Okay. So What we're going to be talking about on today's show is what is premenopause, what is perimenopause, what is postmenopause, and then we're going to talk about a lot of stuff to do with hormones and these different phases of being a woman in a human body on planet Earth.
Okay.
So what is the difference between premenopause, perimenopause, and postmenopause?
Okay. Premenopause is that time in a woman's life from menarche to menopause.
So what's menarche?
Menarche is when a woman first starts having periods. It used to be around age 13. Now it's moving up. So women are starting to get their periods, start their periods around 11 or 12. And then menopause, average age of menopause is 50, with the range being 45 to 55. So premenopause technically are those 30 years or so. Perimenopause is a time in that premenopausal time frame where we begin to see hormonal changes in a woman. So from like maybe the mid-30s until age 50, you might see fluctuations in estrogen, falling levels of progesterone. So during that time, women may experience more breast tenderness, more menstrual changes, heavier periods, irregular periods, more depression, more anxiety, difficulty with sleep, decreased libido, and so on. And a lot of those symptoms create a lot of discord in marriages. And I always tell the audience when I'm lecturing that if you have a couple that's in that age group and they're having marital difficulties, make sure that you check their hormones before they go to the divorce lawyer.
It's totally true. Totally true.
Absolutely. Once, and guys too. Guys go through what I call menopause. So I mean, the medical term is andropause, but I call it menopause because the guys are having the same issues. Their testosterone is falling. They're losing their lust for life, the things that used to give them pleasure. And women experience this too. It's called anhedonia. Men start to have
What is it called? What is it called?
Anhedonia.
And how do you spell that? And what does that mean?
Anhedonia. An is without. Hedonism is pleasure. So you lose life's pleasures, things that you used to enjoy doing, you don't enjoy doing anymore. So rather than going out with your wife and another couple and having fun, you might want to sit on the couch, drink a beer, and watch the baseball game, or you don't want to do anything. So men and women both go through that. But when a woman it becomes perimenopausal, that is a really important time to evaluate her hormones because that's the time when you start to see the greatest rise in the slope of the curve for the incidence of breast cancer. So breast cancer premenopausally, pre-30, age 35 is usually very, very low. About 85 or 90% of the breast cancers are diagnosed postmenopausally. But during that 15 years, that 35 to 50, is when you see that curve, the slope, rise dramatically. And a lot of that has to do with estrogen exposure, progesterone deficiency, because there are studies that look at the protective benefits of progesterone and a certain estrogen called estriol on the breast. During that time, it may have to do with the number of children a woman has. The more children she has, the less likely she is to develop breast cancer. Compared to a woman who's never had children, her risk of having breast cancer is higher.
Right, because the pregnancy hormones are progesterone and estriol, and those are the hormones that most protect your breast and your ovary and your uterus, and this is well documented, and that's why when we like to give hormone replacement, we don't say if you don't have a uterus you don't need progesterone. We say no progesterone, and this forgotten estrogen, estriol, are very protective, especially for your breasts.
That's exactly correct, and estriol is the dominant estrogen during pregnancy. And progesterone levels can rise tenfold easily from 20 to 30 milligrams a day to 200 to 500 milligrams a day. And in twins, it's at least that high. So you're right; those two factors alone are important protecting the breast. There are other factors, but those are the big ones. And then postmenopause is that time in a woman's life when she stops having periods. Now, at that point, her ovaries are no longer making significant amounts of estrogen. They're making very, very small amounts, if any at all. But they're not non-functional. they still make a little bit of testosterone. And that's why when women are postmenopausal, you remember the old picture of the little old Italian woman, for instance, and she's got her dress on and her stockings rolled up around her ankles, and she's got the little black hairs. And it's not because she was taking hormones, it's because her testosterone now becomes the dominant androgen, becomes more dominant because
androgens being a male hormone.
Correct. So progesterone and estrogen are no longer being made. They are anti-androgenic. They oppose the action of testosterone. In a postmenopausal woman, when you don't have those hormones anymore, the level of testosterone doesn't go up. It actually goes down. But because there's no opposing hormones, now the effect of testosterone becomes more dominant, and you can start to see hair growth. So when women say, I don't want to take hormones because I don't want to grow hair, I tell them that's the reason you should take hormones, because if you don't, you probably will grow hair. So there's a lot of misinformation, a lot of misconception about hormones amongst doctors especially, but amongst patients, what they read in magazines and so on.
I want to talk to you about that a little bit more, but I want to say one thing. So we just gave, and you just gave, a wonderful definition of premenopause, perimenopause, and postmenopause, and you gave the general ages, but when I was a scholar at the Center for Bioenvironmental Research, there's a lot of peer review reproduced data, which is the gold standard of research, that's showing that, you made a mention of it, that women are starting to menstruate earlier. They're even starting to go into perimenopause earlier, and they're starting to go into menopause earlier because of hormone-altering chemicals that are ubiquitous in our air, water, and food. And when the milestones of reproduction are changing, it's a flashing red light on the dashboard of humanity that we're in trouble.
Yeah.
But the problem is, so I don't know about you, but I'm seeing more and more young women that are in their mid-20s that are having perimenopause-like symptoms, but no one's thinking about that because they're so young, even though there's been studies to suggest it. There was a study that just came out of Harvard where they took 14 to 20-year-old girls that had all these health issues and noticed that they were insufficient in estrogen and gave them estrogen patches to 14-year-old girls for a year. And why would that be that they would need to give estrogen replacement other than excessive exercise and having no body fat? But we're seeing a change in these major phases of a woman's life. And so you want your doctor to be a thinker and aware of all this.
You're right. And it's interesting because I've got several women in their 20s now that I have on cyclic progesterone, where typically before it would be the mid to late 30s. So I'm starting to see that. I just put a 14-year-old girl, actually, no, she's 11. I put her on the estrogen patch, but it's for a different reason. She has Marfan syndrome, and we want to close her epiphyse so that that she doesn't. She's already very, very tall for her age, so she's on an estradiol patch. But you're right; these women are coming in earlier and earlier, and what gynecologists are doing is they're putting them on the birth control pill, which shuts down their ovaries, of course, but the progestin that's in the pill is just not very good. In fact, it's darn dangerous. I wish they'd take the pill off the market.
And if you've got an environmental, genetic trigger, it causes leaky gut. That's one of the talks I give in the gut symposium.
Absolutely.
Is the role of oral contraception in damaging the gut wall.
Absolutely.
Right.
Or they're putting them on the Mirena IUD and telling them that it has progesterone in it. Well, it does not. It has a synthetic progestin. And when you look at the breast cancer literature in postmenopausal women and the incidence of breast cancer in those women based upon the type of hormones that they take, the women that take conventional hormone replacement therapy, including birth control pills, have a 69% increase in the incidence of breast cancer, where a woman that takes any kind of estrogen with bioidentical progesterone, the incidence of cancer in that population approaches the premenopausal rate, which is very low. So the hormones are not all the same, and they're not very good. I encourage patients to get off the birth control pill or not to take it. I encourage patients not to use a Mirena IUD.
Well, I'm so glad you brought this up. I recently just had a patient who is a dynamic, sexy, lovely young woman, an entrepreneur. But a few years ago, she got the Mirena. She got the copper IUD. She didn't get the Mirena, different IUD.
Okay. That's the Paragard. Yep.
Right, the Paragard. And she was put on that, and a year later, she started to have recurrent infections. She had sinus infections, ear infections. She had kidney infections. She had to go on Cipro multiple times. She had multiple infections, and she was wondering if the copper, we ran the copper levels in her red blood cell levels, and they weren't elevated, but they were out of ratio, proper ratio with zinc. But we were thinking that probably her body could not handle the copper. So do you think that's possible? Have you seen problems with women on the copper IUD having systemic health issues? And what are other options for birth control? Darn it.
All right. Since I don't do gynecology anymore, I don't see a lot of patients with that. So I have not seen that. But you said something that was very important. You said the ratio was out of copper, with the copper was out of whack with their zinc.
Right.
Okay. And we know that those are opposing elements. So when I put people on zinc, we have to give them copper replacement. It's a 20-to-1, as you know. And I have them take the zinc and copper at separate times in the day. So I wonder if you take a patient who has the copper IUD, if maybe she's just not zinc deficient. So maybe giving her zinc would have made a difference.
Well, that was one of the things I said, because for every hormone to work, you need locally in the receptor where the rubber meets the road, that's that little satellite dish that's waiting to receive the hormone signal. You need atoms of zinc that act like a zinc finger to pull the hormone into the gene to do the thing hormones should magically do. So if there is a lack of balance or optimal level of zinc, your hormones won't work right. Correct. So that leads, so women constantly say, or the moms say, what can I do? My daughter's getting her PhD. She doesn't want to get pregnant. What are alternatives besides holding an aspirin between your knees? Is the old alternative was recommended by the family docs. What do you say, Dr. Jack?
Well, that's the toughest question that I think I have to answer, because really there's nothing else except foaming condoms. That's really the only other thing non-hormonal. Now, if a woman in a situation like that absolutely, positively has to use some hormonal contraception, there are two things that I tell them. If you're going to use the NuvaRing, for instance, the NuvaRing is a hormone-embedded ring that you insert into the vagina and you leave it there for 21 days, and then you take it out and you have a period. It's just like a birth control pill.
It's methanyl estradiol, though, right? Is that what that is?
That's correct.
Okay.
That's correct. But the difference is, and what makes it a little bit better than the birth control pill, is it's a transdermal delivery system, so at least you're bypassing the liver the first pass.
And there's no progestin in it, right?
Oh no, there's progestin
there
in
is?
it too. Oh yeah,
okay.
Unfortunately.
Oh.
But it bypasses the liver, so, and it's transdermal. So if you had to use a hormonal contraceptive, that would be one that I don't favor it, but I say, listen, at least try it. But I always tell patients, whether they're using the NuvaRing or the birth control pill, take a break. So maybe every 6 months, take a month or two off, have a couple of normal cycles, and then go back on it again. Give yourself that month or two break in there instead of using the birth control pill for 20 or 30 years consecutively.
And that keeps the crosstalk between the brain and your hormones alive rather than really shutting it down.
Yeah, well, it gives the receptors a chance to recover and see normal hormones again, and it also reduces the exposure to these chemicals. Other than that, unfortunately, there really isn't a problem. The female condom never was very popular. The diaphragm is another option. That's usually a difficult thing. Most women don't like to use it, and they don't use it correctly. And if they don't use it correctly, then they usually end up pregnant. And if we're putting a woman on progesterone in perimenopause, that's going to also increase her fertility. So it kind of compounds the felony a little bit if they don't want to have a pregnancy. But I think that woman who has the Paragard, and the Paragard's a 10-year IUD, measuring those levels as you did, first thing I do is I give her some high doses of zinc and see if that doesn't make her feel better.
That was exactly my thinking.
Yeah,
so isn't the other thing that I don't know why gynecologists don't do this, but if you're going to hand a woman a script for contraception hormones, ethinyl estradiol and progestins, rinse out of the body more nutrients than any other med that's ever been designed. And if a woman goes off the pill and then has a baby born within a few months, the baby's born deficient in the same nutrients she is. So there's a list of nutrients that if you were to take these nutrients while you're on the contraception, you will have possibly less adverse events. And so let's summarize those nutrients that birth control pills rinse out of the body.
Okay.
It's zinc, and it's folate, and it's vitamin C, and copper, and am I missing anything? Magnesium.
Yeah.
And there's one or two others. I think it's 7 nutrients. I think it's manganese, and there's one other one. I'm trying to remember. I don't remember.
I'm trying to remember.
But it's like roto-rootering your body out of nutrients, which sets you up for having more issues. And maybe if you took those and made sure you had good nutrition and a balanced multi-mineral or vitamin, maybe you wouldn't have gut wall damage and other issues linked potentially.
It's so funny that you should mention that, because I'm moving my practice. So I'm moving out of where I'm practicing into another area in the Nashville area. And one of the services, I'm going to get a bigger office, and one of the services that I want to introduce is IV therapy. And so we can replace those nutrients in patients, say they're on the birth control pill and they want to get pregnant, come off the birth control pill, use another method. We do some IV infusion, we replenish those nutrients, and give you a better chance of having a healthy baby.
Oh, that's great. That's great. So when I come and hang out with you in September, can you show me where you're going to move to?
Well, if I have it firmed up, absolutely. But I'll show you some of the places that we're looking at.
Okay, great. I'm excited.
We're very excited too, because I have a nurse practitioner who's going to be working with me. I have a nutritionist. We'll have a weight management program. We'll have dietetic counseling. We'll have IV therapy. And I've got an esthetician who I just met today, who I'm going to talk to about working there. And I want to have a laboratory in my office, like one of the major laboratories, to draw blood for my patients and for patients that come in off the street. So we're trying to make it into more of a holistic, almost like a medi-spa center.
Oh, I love it.
Yeah.
So, Dr. Monaco, why is there so much confusion and so many different opinions about menopause and hormones between the people who supposedly should be distributing this and be the Blarney Stone for this, the gynecologists, even nurse practitioners? Why is there so much difference of opinion?
I think a lot of it has to do with the training. None of this is ever taught in a traditional gynecologic residency. We're indoctrinated by the drug companies. I remember my first day of medical school, we had one of the major drug companies come in and talk to us and greet us and congratulate us. And then as we walked out of the auditorium, each one of us was handed a little doctor's bag with a stethoscope, a tuning fork, and a reflex hammer. So the first day of medical school, you were tied to the drug companies, and you were you felt like a real doctor, even though you had no knowledge of anything. You were just a college graduate that was starting medical school. That has since changed. The government has come down on the drug companies, and they can't do that. But most doctors are visited by drug reps, and the drug reps tell them about their products. And I'm not saying that all drugs are bad, but a lot of times when you're a busy gynecologist, when I was a busy gynecologist, I would see 40, 50 patients a day. I don't have time to sit down and chit chat with the drug reps or with other people. So the drug rep would come in and say, "Hey doc, we got a new product. I'm leaving an article on your desk. I'll put some in your closet. Give me 2 minutes," and he would give me a little 2-minute speech, and that would be that. And then at the end of the day, after I've seen all those patients and I finished my charting, then I'd look at the article and see what it is. And it's like, oh, okay, so we have another new drug for whatever. And unfortunately, that's where a lot of doctors get their information. And they don't have time because of the way conventional medicine is being structured now. And I blame the insurance companies for that. We used to be able to spend time with patients. Now doctors have to see more patients, spend less time with them. And right now they're not thinking outside the box. They're busy, general OBGYNs, and they're really not well trained to do hormones. I was not well trained. Okay, I spent many, many thousands of dollars and many, many hours of time to go back and learn about hormones and functional medicine. And let me tell you, it was about 350 hours of lecture that I went through to learn about these things. So conventional docs aren't going to do that.
Boy, it's so interesting that people don't realize it. They feel like if someone's a doctor, they know this. They've been exposed to this. You know, Nashville is so lucky to have you. We don't have a doctor like you here in Austin. I really mean that. People constantly are writing me. They're emailing me, they're writing me, they're getting through some portal. There's so many portals of communication now, it's hard to keep track. And they're always saying, can you recommend somebody who knows hormones really well in blah, 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 blah? And you know, Dr. Jack, there's very few people I can recommend. Even naturopaths. There's some people that are training the naturopaths in certain schools. I'm not going to say exactly who, and it's all medical, and they don't believe you need progesterone if you don't have a uterus. They don't believe in estradiol. So you don't know how to find a great doc like you. And so I really want you to keep on the lecture circuit and keep training other docs because there's not enough of you.
As long as people ask me to lecture, I will lecture. But I'll tell you, we don't have anybody like you up here. So why don't you come to Nashville, okay? I know you got cowboy boots, and I know you can dance. So you can come to Nashville, and we'll work together. And seriously, one of the things that I'm going to do is I'm putting together a mini concierge package where patients can come from a distance, have all their tests done in their hometown, their blood work, their advanced lipid testing, their salivary testing. All of those things can be done if it's a menopausal patient and we need to look at her heart, her blood vessels. Then we can do a cardiac ultrasound. We can do a cardiac ultrasound. We can do abdominal ultrasound.
Let me jump on that 1 second. I know you're listing what you can do. So a lot of times women say, why can't I just get hormones? And some doctors that are getting hormones, they'll just run your blood levels and just give them to you. But you and I, we know that this is taught in functional medicine, that if you're already old enough to have some amount of heart disease, you might not be a candidate for bioidentical hormones or any hormones, that you have to have that heart disease, quote, fixed before. So can you explain that? Because very few, even functional doctors, approach that very important nuance of safety with bioidentical hormone replacement or any hormone replacement.
Yeah. Well, you know, it's really difficult, Lindsay, to figure out which woman is going to be a candidate or have risk when you give them hormones postmenopausally. The way to tell, there are a couple of tests that you can do. There's a lot of things that are still in the research stage. Generally speaking, if you look at women 10 to 15 years out from menopause who don't take hormones, they are at increased risk of developing cardiovascular disease. In other words, in that population, their incidence of cardiovascular disease is approaching the male rate.
So you're saying if you're so the average age of menopause is 50. So you're saying if someone's about 65 and they were never on any hormones, at that age, they're at risk of heart disease. And you've got to figure out if they have some heart disease. Yeah. Because otherwise giving hormones can worsen that in the early stage. So
yes and no.
Okay.
Yes and no. They are statistically at increased risk. In other words, by 15 years out, the incidence of women with heart disease is approaching the male rate. Okay. Now, some women are more than 15, 16 years out, and they do fine. So now you take that subset of women that are 15 years out from menopause, and you test them. And then a small percentage of those women may have pre-existing or established cardiovascular disease.
And what are those tests? Can you name those few tests?
So we would do a carotid ultrasound with a CIMT. An IMT, it's a test where they measure the lumen of the carotid artery.
The opening.
And the thickness of the wall of the carotid artery. artery, and there's a ratio, it's called the intima media thickness. And they measure the ratio of the thickness of that artery to the opening in the artery. And if it's above a certain number, then statistically they're at an increased risk of having a cardiac event. Okay, so you look at the carotid artery, see if there's any plaque in there, and you do that measurement. Then you do a cardiac echo, and you see what their ejection fraction is. That's how much blood is pumped out with each beat of the heart. You look at the wall motion. The wall between the ventricles moves when there's a contraction, and that movement is very important. You can look at the thickness of the ventricle. And if a woman has a very thick ventricle, then she has some pre-existing condition that's causing. It's like exercising a muscle. You know, if you lift weights, your muscles are going to get bigger. If that heart is working really hard to pump, it's going to become thicker. Okay, we look at the abdominal aorta and see if there's anything there. We can do something called a calcium score, which is a CT scan. It's called an ultrafast CT scan, and we can see if there's any calcium in the artery. Now, generally speaking, the smaller the artery, the more likely that's where you're going to see changes. So if you have plaques, calcium deposition in the aorta, you can pretty much bet you've got them in the coronary artery. However, if your coronary arteries are clean, you're not likely to see those plaques in the carotids or in the aorta. So the smaller vessels get affected first. So you can do a calcium score and see if there's any calcifications in the arteries of the heart. If the calcium score is 0, their ultrasounds are fine, their carotid IMT is fine, the intima media thickness. If all of those tests are normal, the likelihood is that they are very, very low risk with hormones.
So who are the women that should get these tests if they're thinking of possibly getting hormones?
I would do them in women that have a strong family history of cardiovascular disease, or a woman who's been off hormones for 15 or more years, or
since menopause. Okay.
Or a woman who has been told or has symptoms. You know, maybe she's on medication because she's hypertensive and she's short of breath, or maybe she had an abnormal EKG, but she had a normal cardiac catheterization. So I would do some additional testing on those types of people. And I always ask the question, you know, do you have any cardiovascular symptoms? Are you short of breath on normal exertion? Like you climb up a flight of stairs in your house, you have to stop at the top of the stairs and catch your breath. Do you have difficulty when you lie flat in bed with breathing? Have you ever been told you had heart disease? Do you have any chest pain or any other discomfort? You know, we go through a series of questions. And if all of that is negative, then the likelihood that they have a problem and will have a problem with hormones is pretty small. But we do know that there is a certain segment of the population that has cardiovascular disease that will be at increased risk. That is why it's so important for women to be on the right kind of hormones, in the right dose, and in the right balance at time of menopause.
That is so important to hear because very few docs know that. So, you know, a lot of women say that are wary of hormone replacement or they're wary of getting breast cancer. They say, if God intended for me to have hormones, then I would have continued to have hormones. So it's not natural for me to take hormones because it's not a natural thing. And women, because of the Women's Health Initiative and because of that kind of thinking, are often very frightened. So can you summarize for women what are the true benefits of healthy hormone replacement if you're not one of the people who has heart disease? What can a woman expect to get from balancing her hormones and getting good hormone replacement?
Before I answer that, the answer that I give to women when they say that if God wanted us to have hormones, we would continue to have hormones, I tell them, I say, the only reason a woman has a period is to reproduce, okay? And God knew that you didn't want to have a baby when you were 80, okay? But the other thing is when patients say it's natural for our hormones to decline as we get older, so we shouldn't be messing around with Mother Nature, I usually look at them and say, I see that you're wearing glasses, and it's natural for your eyesight to deteriorate as you're getting older. So if we're going to use that same logic that you're using about hormones, you should not be wearing glasses, all right? Because that's messing with the natural course of aging, Okay. But when you look at these hormones, and again,
look at how many facelifts are done a year to avoid aging. Some of these very same women have had a lot of, God bless them, a lot of procedures and look great. But there's a lot that we live in an age of technology being able to slow down aging. Yeah.
But look at how much emphasis we place on thinness and beauty and youth. You know, you don't see too many, old, fat, ugly people on magazines. Okay, so most of it are beautiful women, muscular men, they're all young and vital. And that's okay. But society seems to put such pressure on us to maintain that youthful appearance that we start going to the plastic surgeon and we want to stay young forever. I will tell you that when you look at hormones, the benefits of hormones are really too numerous to count. Estrogen has over 400 functions in the body. You even have estrogen receptors in your eye. So a lot of women that are menopausal might even have dry eye. Estrogen helps to plump up the skin, so it gets rid of those little wrinkles because estrogen causes water retention. And as you get older and you're making less estrogen, you essentially become dehydrated. So your skin becomes dehydrated. Estrogen protects the heart. Estrogen is important for metabolism of cholesterol. Estrogen is important for preventing bone loss and many, many other things. Estrogen is a vasodilator, causes the blood vessels to dilate, which is a good thing. Estrogen protects the heart. When you look at progesterone, the only similarities between progesterone and the non-bioidentical progestins, that is the hormones that you find in the birth control pill, the Mirena IUD, the NuvaRing, and postmenopausal hormones. The only two similarities is that both progestins and progesterone will regulate menstrual bleeding, and both will protect the endometrium, the lining of the uterus, from developing cancer. After that, they're exactly the opposite. Some of the benefits of progesterone. Progesterone thickens your hair. It's anxiolytic, meaning that it acts like an anti-anxiety, it has an anti-anxiety effect. It has an antidepressant effect. It has a diuretic effect, so it helps to get rid of some of the water retention, the breast discomfort that women see when they have excess estrogen. Progesterone stimulates sleep, so it helps with some of the sleep disorders that women will see when they're perimenopausal and menopausal. Progesterone lowers blood pressure if it's elevated. Progesterone does not increase your risk of stroke and heart attack like the progestins do. In fact, progesterone, progesterone normalizes the clotting in the blood. Progesterone stimulates the cells in the bone to build new bone. So remodeling the bone is a process. The skeletal system is not like the studs in the wall. It's constantly undergoing remodeling. So it's breaking down old bone and laying down new bone. So estrogen decreases that excess bone loss that you see with menopause, and progesterone stimulates the cells that rebuild the new bone. Progesterone is important for thyroid function. Progesterone helps to metabolize cholesterol along with estrogen. Progesterone is a precursor to cortisol, the hormone of stress from the adrenal glands. So progesterone is exceedingly important. Protects the endometrium. It protects the breasts. It balances the 400 functions of estrogen. And postmenopausal women who take hormones will not have periods for the rest of their life. They're not going to start having periods again because the dosing that we use is actually very low. And that's a very important point. You do not need a lot of hormone to get the benefits of hormones. Doctors very often overdose patients on hormones because they're treating the symptom. So they'll give a hormone, the symptom goes away, and then it comes back. And the knee-jerk reflex is to increase the dose. So they increase the dose, the symptom goes away, it comes back again, they increase the dose. And they keep doing this until they can't go any higher. And then they tell the patient, well, it's not your estrogen or your hormones. I can't go any higher. Maybe you're depressed. Maybe you should see a psychiatrist. And then they end up on an antidepressant. Okay. So the right balance of hormones is very important. What's happening in that situation is the body is designed, the receptors that you've mentioned, those little satellite dishes, they are designed to shut down when it sees too much hormone. It's a protective mechanism. So when you overstimulate those receptors, you'll get an effect for a short time, and then the effect goes away because the receptor has shut down. It's like insulin resistance. Once the cell sees too much insulin, now it requires more insulin to get your blood sugar down until eventually it can't keep up and you become a diabetic. So hormone receptor is very important. That's where dose comes in. And most doctors tend to overdose patients because A, they treat the symptom and they keep upping the dose, or B, they give them a topical hormone and they do a blood test where you don't see these hormones and they increase the dose.
You know, I just had a patient who went to see a naturopath in another town and who put her on 6 milligrams of estrogen, and she felt great for 2 months, and then for 2 years she felt like she wanted to die. That's the old dose of estrogen when they treated breast cancer patients because it shut down the estrogen receptor with that dose. And there's a woman out there called Wiley that recommends the Wiley protocol. I got 5 emails on the Wiley protocol. I think she was on the Bulletproof radio show this week or last week or something, and she's recommending giving hormones to the place where women menstruate, and it's very high dose, and I've had quite a number of patients on that protocol get breast cancer. Can you comment on that?
Oh, boy, can I comment on that. Okay. Let me tell you, this is why the United States is such a great country, because anybody can get on a radio show and say anything that they want, and somebody will believe them, okay? T.S. Wiley, to my knowledge, now she may have finally graduated, to my knowledge, she did not graduate from college. She was an anthropology major.
I had dinner with her one night.
Oh, she's a great marketer.
Yeah, really.
Oh, she's a personality. I mean,
yeah.
But anyhow, she came up with this concept that women should menstruate because it keeps them young, and that's the way God intended it.
And the biometrics of mimicking how, but it's exactly. Very dangerous protocol.
Oh, it is.
Yeah.
So what she did was she puts these women on scary high doses, okay? I had a patient who was on the Wiley protocol, and the doctor that put her on this protocol, I don't like to speak badly of my colleagues, but she was trained in hormones, and put her on the Wiley protocol. This woman was in her 60s. She was about 89 pounds. And she put her on 16 milligrams of straight estradiol. She put her on 600 milligrams of progesterone. This woman's fibroid started to grow again. She started to bleed. Her breasts enlarged, and they became very tender, and the doctor didn't know why. She happens to be a colleague who worked with my wife when we were in Connecticut. So my wife finally convinced her to come and see me. And I measured her levels, her salivary levels, and they were off the charts. It was amazing how high they were. I stopped all of these hormones, and I said, you're going to have a bumpy ride down. I said, hang in there. I said, as soon as you get down to baseline, I'll fix it for you. So I weaned her. I started to wean her down off this dose. Finally got her down to baseline. Her breast tenderness went away. Her fibroid stopped growing and actually shrunk down, and her bleeding stopped. And I put her on bioidentical physiologic doses. Let me explain what a physiologic dose is. A physiologic dose is the amount of hormone that a woman would make mid-cycle during her mid-30s. Okay? So for estradiol, a woman makes between 0.05 and 0.7 milligrams. Okay? That's a very, very tiny dose. So I give my patients somewhere between 1, maybe 2 milligrams of biased, which is only 50% estradiol. So my patients are getting somewhere between 0.05 and zero point 0.1 milligrams of estradiol. This woman was getting 16 milligrams of estradiol. Okay?
So
unbelievable.
What's really interesting is that the old-time CEOs of the Prempro and Premarin companies, and they used to badmouth bioidentical hormones incredibly. And now because of the Women's Health Initiative, all of the negative effects were done with women taking those synthetic hormones. Right. So that those companies really went down in sales. Those guys have reconnoitered. They've now opened up their own company. I think it's called Medical Therapeutics. They've come out with their own bioidentical hormone oral product called Replenish. It's gone through phase 1 and phase 2 trials. It's in phase 3 trials. They're starting to publish in peer-reviewed data, the summations of phase 1 and 2, saying it's very clear that bioidentical hormones are safer, they're more efficacious. But see, now these guys are going to be selling it, but they're giving it oral, which we're going to want to make a comment on that. But follow the money. A lot of what women were told for so long was because the money was guiding the decisions and the guidance that they were being given. It wasn't based on physiology.
And you know who commissioned the WHI? These very same companies, to show how safe their hormones were. And they shot themselves in the foot, all right, because they showed how dangerous they were. So they did exactly what
WHI was the Women's Health Initiative for everyone.
Yeah, and that was stopped 2 years early in 2003 because of an increase in breast cancer, strokes, and heart attacks.
And everyone got worried, but it was because they were the synthetic hormones, and women had been not on the hormones for 16 years. Most of them were in their mid-60s. They were overweight. It was a totally different population than you walking into your doc's office, being 51 and asking these questions.
And then the American College came out with their policy statement, which said, we don't recommend that women take hormones postmenopausally, ignoring all the literature and the positive benefits of properly administered hormones. However, if a woman has severe symptoms, then it's okay to use these hormones for no more than 5 years at the lowest possible dose, okay? There's one study, I think, from Finland that came out, and again, flies in the face of all the other
I think
literature.
I sent you that study. Is that
no,
the
you
one?
You sent me the other study. This is a different study.
Oh, you're not talking about the one that was published in ACOG? You're the one on the 130,000 women over 14 years? No, not that one?
No, I'm talking about this Finnish study that came out and said that women who took hormones and then stopped them were at increased risk of a cardiac event. So that's where the ACOG,
I sent you that study.
Okay, so you sent me that study. So that's where ACOG came up with the 5 years, okay?
Yeah.
But then another study that you sent me from the University of Helsinki Hospital Department of OBGYN looked at all of these women, and they found that when women were taking hormones and then stopped them, there was an increased risk of cardiovascular events in the first year after stopping those hormones. So now you've got doctors telling patients that it's okay to take the hormones that the WHI showed were unsafe for no more than 5 years based upon one study. But another study released their findings that said when you take these hormones and stop them, you're actually increasing your risk of having a problem. And unfortunately, that's what the gynecologists read and that's what they see.
So in other words, if you stay on the hormones, it protects your heart.
If you're on the right hormones, and the right balance and so on, yes, these are very beneficial hormones. Patients ask me, how long should I be on the hormones? And I say, until either you die, I die, or I retire, okay? and I say that half seriously and half jokingly, and I tell them these hormones are very, very safe if they're done correctly. If they're not done correctly, then you shouldn't be on them. You should be on the right kind of hormones.
You know, I had breast cancer about 24 years ago, and most doctors these days, their guidelines are if a woman had a history of mammary tumors, she should not be taking hormone replacement. But balancing my hormones made me a better woman and less apt for recurrence. So I've been on bioidentical hormones now for 18 years, but a lot depends on the type, the tumor you had, the profiling of the tumor, et cetera. There's lots of different things, but there isn't one set guideline that applies to all women.
No, it's very individualized. You're absolutely right. Very individualized.
Now, one question women say to me, I have a certain number of ladies who go on hormones. They need them. They go on a small amount of hormones, but they gain weight. And these are women often who have had to really do Herculean effort to be at the wonderful weight they now are at. So that's their biggest concern. Can you discuss weight gain on hormone replacement and what to do and what that means?
Sure. There are several reasons, there are several factors that are involved in weight gain. The obvious things are activity level, portion size, the types of foods that people eat. But the adrenals, the thyroid are very important. And a lot of people have a thyroid dysfunction that's not recognized by conventional medicine because the two tests that doctors do are normal, but their thyroid really isn't working very well. There was an animal study that looked at weight gain in laboratory animals after their ovaries were removed. And what they did is they castrated these rats and they observed them. And what they found was that the rats ate voraciously and they gained weight quickly. So then they said, all right, we're just feeding them too much. So they did another group of rats, castrated them. Half of the rats, they let them eat whatever they wanted. The other half, they restricted their calories. Both groups gained weight quickly. The difference is the group that had the restricted calories, they stopped moving. The only time they moved was to go eat. So they stopped exercising, okay? So then they said, well, maybe the hormone has something to do with it. So they took another group and they castrated them. One group they let eat everything that they wanted and didn't give them any hormones. The other group, they let them eat anything that they wanted and gave them estrogen, and that group did not gain weight. So the hormones, it's flies against the conventional wisdom. Everybody associates weight gain with hormones. But if you're using the right kind of hormones properly balanced, then you should not gain weight. But again, there are other factors. Now, progesterone is important for thyroid function, okay? So if you're not getting enough progesterone, like that Wiley protocol, that woman was so estrogen dominant, even though she was getting 600 milligrams of progesterone, which is more than most women make in pregnancy, she was getting so much estrogen that she was actually progesterone deficient. So when we talk about hormones, it's not just the level of hormone that's important, it's the relationship of those hormones. So a woman can have a high level of estrogen, but a relatively low level of progesterone and be estrogen dominant. Or she can be estrogen dominant by having a normal level of estrogen and a low level of progesterone. So it's really the balance that's important.
You know, we're learning so many new hats that estrogen wears, like it rules epigenetics, it protects mitochondria from damage, and it really has huge influence on your fat cells that you carry on your body. Estrogen oversees bioenergetics of your lipids stored in your adipose tissue. And in fact, I have a little course now called Everything Estrogen. I have I'm opening up a little Berkson University on Thinkific, and a lot of talks that I've been giving around the country. I'm making shorter versions, some for smart patients and some for doctors. And I've got a course called Everything Estrogen, which is explaining all the new roles. It's about a 2 or 3 hour course. And we do know that estrogen oversees fat cells on your body, and that if your estrogen is healthier and in healthier, younger levels, you don't have such a power of the battle of the bulge. Such a horror with that. Well,
you have estrogen receptors in the endothelium of your blood vessels,
right?
And that's very important.
You know, your brain. Oh, sorry, didn't mean to interrupt you.
I was just saying the estrogen receptors are different. So in the breast, for instance, the alpha receptor is not good. The beta receptor is. But in the heart and some of the blood vessels, it's just the opposite. So that's where the balance comes in. Too much of a hormone can be actually detrimental, and that's the problem, is that doctors tend to treat symptoms. They end up giving the patient more estrogen and more hormones than they need, and that's when you start seeing problems.
And many women, of course, now, they used to be frightened of the big C, cancer, and now they're frightened of the other C, cognitive decline.
Oh, yeah.
And estrogen runs your hippocampus that protects your memories and your cognition. In a healthy middle-aged person, estrogen is produced in 6 different areas of the brain to keep your brain healthy, happy, and blinkful, and keeping your hormones at a healthy level, individualized for your situation, usually even turns off the expression of the ApoE4 gene that puts you at risk of Alzheimer's. So hormones have a lot to do with protecting against cognitive decline.
Absolutely.
Absolutely.
They're so important. You know, the commonly held motive, if you will, is don't take hormones if you don't have symptoms, or don't take hormones because you're going to get cancer. I will tell you that I agree 100%. I agree 1,000% with you. Hormones, if they're correctly done, and that's really the underlined and highlighted. If these hormones are correctly done, they are very, very, very beneficial. Heart disease is still the number one non-cancer killer of men and women in this country.
Right, and hormone replacement protects against heart disease, and
it does.
It's the number one killer of women of all ages. And you know, one of the things is that you can also eat to protect your hormones, Dr. Jack.
Absolutely.
And flax seeds have a lot to do with protecting your hormones. And if people go to my website, drlindseyberkson.com, I have put together my very favorite flaxseed recipes that are so delicious. I have a flaxseed muffin recipe that people just write me over and over again how much they love. I have a high-dose flaxseed if you've had breast cancer and you don't want to have recurrence, endometrial cancer, ovarian cancer, very high dose. So I have 2 different muffin recipes. I have a cereal recipe, and I even have a macadamia nut frosting and pudding that Mexico research has shown that macadamia nuts, which are high in omega-7 fatty acids, tamp down inflammatory cytokines and even tamp down their genes. This has been in gastroenterology research. So you can eat food to get these benefits, and if you're on hormones or not on hormones, you can eat some foods to protect the hormones that you've got left. And if you go to drlindseyberkson.com and sign up for my website, right now you'll get that free little ebook that is so yummy in your tummy.
I'll have to tell Lisa about that website. So she's got to go there and start doing this stuff. She's still not listening. But anyhow,
I've tried to encourage her about food, but when I come to Nashville in September, I'm going to stay with you guys for a hunk of time, and I'm going to go into the kitchen and I'm going to do some Lindsay magic for you, because I love cooking, and I'm going to share and see if I can jumpstart her or reboot her. Okay.
We got to see if we can get you to move to Nashville.
We'll have to go out dancing. Well, thank you so much for being on the show, Dr. Jack. Dr. Jack Monaco. I met him lecturing, and then it was a match made in heaven, because we really recognized that we love the literature, but we cared so much about truth and people. And it's really great. He looks like he's out of New Jersey, like he's the New Jersey.
Well, I am.
You have so much smart plus heart. I've really grown to love you, Jack. I really have.
And the feeling is mutual. But I was actually born in the same town as Lou Costello. So he was a little older than I was, and I never met him. But he was born in Paterson, New Jersey, and that's where I was born.
Well, you sound a little bit like you come from there.
I'm a Jersey boy, Like Lisa says, she said it's a great place to be from.
And now you're in Nashville, and they're really lucky to have you. And we were lucky to have you on this show today. Well, this was a lot of very helpful information, because the aging demographic is the fastest growing demographic in the country, and a lot of women are given wrong information, and you learned a lot of right information here today. Thank you for giving me this time on your Sunday, Dr. Jack, and I'm going to see you soon in Tennessee.
Yes, I look forward to that. Thank you for having me, and next time let's talk about the guys.
Okay, next time let's have a show on the guys.
We'll do menopause.
Menopause, I love that. Okay, blessings.
All right,
thank you so much. Bye-bye.
Thank you. Bye-bye.